Welcome to TCCC-Plus Day 1, Module 10 about circulation and shock. Here we cover recognizing early and late shock and the ASM job of controlling the cause. Shock is the state where the body is not getting the oxygen-carrying blood it needs from blood loss or from a failure to move the blood around. In combat trauma, it is almost always due to blood loss, and as we should know by now, blood loss is what kills most people in combat. You recognize shock without any fancy equipment or monitors, but read it off the casualty. As the body loses blood, it compensates in a predictable order. First, it speeds the heart and breathing and shunts blood away from the skin to protect the core, so the early casualty is anxious and restless, with pale, cool, clammy skin, breathing fast, is thirsty and weak. Only when those defences are exhausted does the blood pressure fall, and by then they are confused, drowsy, with weak or absent pulses, sliding toward unconsciousness. That is the key point. A falling blood pressure is a late sign of blood loss. Do not wait for it. By the time the pressure drops, a lot of the tank is already gone, and there is a high likelihood that they will die. The short version, the one on your card, is this: altered mental status without a head injury, or a weak or absent radial pulse. Either one on its own means shock, and either one is enough to act on. To illustrate this, we can read the curve. In hemorrhagic shock, that is shock due to bleeding, heart rate and breathing climb early, while blood pressure holds stable for a long time before it crashes late. By the time the pressure drops, the casualty is already deep in shock. This makes it important to act on the early signs, a fast pulse and fast breathing. When it comes to interventions, stay in your lane. Stop the bleeding, keep them warm, reassess often, and get help. The definitive treatment for hemorrhagic shock is blood and surgery, not the bags of clear fluid you may have seen used in the past, which do not carry oxygen and which the guidelines have stepped away from for bleeding trauma. They dilute clotting factors and platelets while increasing blood pressure, overall increasing bleeding and mortality. Your job at this level involves none of this, but is to control the bleeding and get them to the people who can give blood. One thing you can do is fluids by mouth, but only for the right casualty. Fully awake, able to swallow, and not in shock. On a long wait, that is worth doing. A shocked casualty gets nothing by mouth, and neither does anyone heading for surgery. And do not forget tension pneumothorax as a cause of shock that bleeding control will not fix. Looking at how we treat shock in different phases, we see the return of basic interventions. While under fire, the shock treatment is the tourniquet, stop the bleed. In tactical field care, recognize, control bleeding, warm, reassess, escalate. And during evacuation, watch the trend and watch for movement and cold worsening the shock. Common errors include waiting for the blood pressure to drop before acting, treating numbers instead of the casualty, and letting a shocked casualty get cold because cold blood will not clot, so a cold, shocked casualty bleeds more. Now let's recap. In early shock, we see a casualty get anxious, pale, cool, fast breathing, weak. In late shock, they get confused, weak pulses, unconscious. You prevent and treat by stopping the bleeding, keep them warm, reassess, and consider a tension pneumothorax. Thanks for watching our TCCC-Plus for Non-Medics Day 1, Module 10 about circulation and shock. Next up is Module 11, Tourniquet Conversion and Replacement.